right, it looks like we're ready to start here. So I'd like to thank everyone for joining us. We're going to talk a little bit about prostate cancer survivorship tonight. This is part of our series on men's health this month and prostate cancer, where we're covering a number of topics from diagnosis to treatment to management of after effects of treatment. So again, we'll be talking about prostate cancer survivorship. I'll introduce our esteemed panel here. I'm Brad Gill, I'm your moderator. I deal with enlarged prostate and urinary issues, as well as erectile dysfunction, and the diagnosis of prostate cancer or elevated PSA. We're also joined by Molly dewitt-foy, who was one of our stellar residents a few years back and went off and did some extra training in urological reconstruction. She manages erectile dysfunction and urinary leakage, as well as urinary stricture disease. Very well equipped and skilled to manage any of the side effects of prostate cancer treatment that can occur. We're also joined by Scott Lundy, who is another one of our stellar prior residents. He stayed on with us and did a fellowship in men's health and reproduction. He sees patients and treats erectile dysfunction, as well as a number of other conditions in sexual medicine and male infertility. As you can see on the page here, we see patients all around Cleveland at the main campus, including some of our satellites at Beechwood and Independence, and then also at Fairview Hospital and Hillcrest Hospital. So we're able to get folks in and help them out no matter which part of Cleveland they're in or which part of the country or world that they're coming from. So prostate cancer is a very common condition. And if you look at the statistics, nearly 1 in 6 men will be diagnosed with prostate cancer during his lifetime. This puts this on a level with breast cancer. And we all know that when you go to the grocery store and you look around, you see pink ribbons everywhere. They're on the yogurt, they're on the bread, they're on the milk. But we don't have that for prostate cancer, and we really should. It's a very common condition that impacts a very large number of men. And it's upon us as guys to really talk about that and make sure that we check in on each other. We talk about screening, we talk about treatment. And if guys have had issues after being treated for prostate cancer, we tell them it's okay to go and get that treated, get that checked into and fix problems with leakage or erections or whatever they may be. So when we think about survivorship, we think about what men and what patients are dealing with after being treated for or diagnosed with a condition. And a number of words, come to mind in terms of a journey through care and treatment and support and family and, a number of the things here on the slide. When we think about prostate cancer and prostate cancer treatments, there's a number of avenues that a man can take. They range from radiation to surgery or radical prostatectomy, to active surveillance, where you monitor the cancer closely to ensure that it doesn't progress, or therapies where you destroy or remove just part of the prostate gland, trying to preserve the rest and just treat the cancer. All of those treatments have different side effects. There are no treatments, there are no management approaches to prostate cancer that don't have side effects. And that's an important thing to know, because a lot of times, if a man experiences side effects of prostate cancer treatment, he can feel regret. And he can say, well, why didn't I choose another treatment? Why didn't I go this way? Why did I go that way? And the important thing to realize is that there's potential side effects to every prostate cancer treatment. But thankfully, these are things that we have ways to manage. So we can fix urinary leakage. We can fix problems with erections. We can fix scar tissue and troubles urinating. Those are all things that we have the ability to help men manage. So without further ado, I'll turn it over to Dr. dewitt-foy here, and she'll touch on some of the urinary problems that men may experience after prostate cancer treatment.
Thanks, Dr. Gill, and thanks everybody for hanging out with us this evening. I'll be talking about the urinary problems that men can get after some different treatments for prostate cancer. So how common are urinary problems after prostatectomy and radiation? The answer is pretty common. So at 15 years after prostatectomy or radiation for prostate cancer, 17 or 18% of men report being bothered by incontinence or leakage of urine. That's a really large number, and we see a lot of those patients in our clinic. And like Dr. Gill said, we have plenty of treatment options. So I'll start talking about what some of those are. So the different urinary symptoms that men tend to have after treatment for prostate cancer, the first is what we call stress incontinence. That's the kind of leakage that you get with physical activity, with coughing, with trying to go to the gym, lifting something heavy, sneezing. Um, Urge incontinence, to contrast with that, is leakage that's associated with a really strong need to urinate. So you're living your life, maybe washing dishes like a patient I saw today in clinic, and you hear that running water and you just absolutely have to go to the bathroom immediately. We call that urge incontinence. Overflow incontinence is incontinence or leakage that results from a bladder that's not emptying well, and it just can't tolerate anymore, and it sort of overflows and leaks because of that. Climacturia or arousal incontinence is incontinence that only happens with erections, with stimulation, or during orgasm or sex. And then all of these are to contrast with obstructive voiding, which is instead of leaking, there's a blockage that's not allowing the bladder to empty completely. And I treat all of these things. So what are the different treatment options for urinary incontinence? For urge incontinence, it tends to be really a medical problem that we treat with medications and behavioral and diet changes. So cutting out caffeine, medications that help the bladder not squeeze uncontrollably, which causes that sensation of urge. Sometimes if those really don't work and people have horrible, horrible urge despite all of those things, then we can do some different procedures or surgeries to fix them. For stress incontinence, this really tends to be a surgical problem. There are some clamps and external devices that we'll talk about, but for the most part, we end up recommending surgery if patients are really bothered and if they're interested in having a surgical procedure. And then for overflow incontinence, the solution is really finding the blockage and unblocking it however we do that. And I'll talk a little bit about how that happens. So treatments for stress incontinence, we've shown a couple of pictures here. I know some of them look like medieval torture devices, but I'll talk through exactly what they are. So the simplest devices, one is called a Texas catheter or condom catheter. That's what you see on the left over here. That goes on just like a condom does, and then it hooks into a drainage bag. So it really just catches the pee as it leaks out. Obviously that's easy. It's an easy thing to put on, but it does have some bothersome side effects. You're walking around with a bag and you're wearing an external device all the time. So I generally recommend that for people who really can't tolerate surgery. And then this medieval looking device on the right over here is called a Cunningham clamp. That's literally a clamp that squeezes the penis so much that the pee doesn't leak out. It looks really comfortable, but I do have some patients who opt for this. And then we sort of talked about the advantages, disadvantages. The surgical treatments, there are sort of two of them. So there's a male urethral sling and then an artificial urinary sphincter. So we'll talk about the male sling first. So this is a really nice treatment for men who have mild or moderate incontinence. And I usually say that's less than 3 pads a day and the pads shouldn't be soaking wet. This is an outpatient surgery. We make a small incision in the perineum, which is the space between the scrotum and the anus. It works, if it's going to work, it works the second it's put in. There's no activating that has to happen. It's all completely contained within the body. Again, this is a good surgery for people who've not had prior radiation, generally who have incontinence as a result of a prostatectomy and have pretty mild incontinence or only have leakage with climax, with arousal, or with orgasm. It's a really nice surgery for those people. The satisfaction rates are sort of in the 70 percentile range if the patients are well chosen. So people who are, pouring urine out all of the time, who get a sling, are generally not that happy. They have some improvement in their incontinence, but it doesn't resolve completely. So another option, surgical option for stress incontinence, is an artificial urinary sphincter. Excuse me. So this is a device that has 3 pieces. The first is a cuff that wraps around the urethra The second is a pump that sits next to the testicle and the scrotum. And then the third is a balloon that's filled with saline that's right in front of the bladder and the pelvis. So the way that it works is it's active all the time. So there's a little bit of salt water that's in that cuff, and it's just sort of gently squeezing the urethra so that the urine can't leak through. And then when you feel like you have to go to the bathroom, you walk in, you activate this pump a couple times by squeezing a pump that's in your scrotum. All of the saline that was sitting in that cuff gets pushed into the pressure regulating balloon. You pee, and it slowly closes back on its own. So it's a really easy to use device. It's an outpatient surgery. Same incision as the sling, that incision in the perineum. It's a mechanical device, so anything mechanical can fail. But I will say the satisfaction rates are incredibly high after the surgery. These are some of the most grateful patients that I have because they've come into me leaking all the time, wet, they can't exercise, they can't go out, they can't do anything. And then suddenly we do this surgery and they're dry, or at least mostly dry. We don't activate it right away, so I do wait a couple weeks after surgery to get it going, but people tend to be really, really happy after this surgery. So treatment for urinary obstruction, so after radiation or after a prostatectomy, you could develop scar tissue, either, for people who've had a prostatectomy, either where the bladder connects to the urethra, where it's sewn together, or for men who've had radiation, either where the radiation was or sort of downstream of that radiation. So a bladder neck contracture after prostate cancer, after prostate surgery or radiation, that's what I was talking about, where the spot right where the bladder meets the urethra has scar tissue. You can see on the left here, there's a really tight opening on the bottom left corner. That opening should be much larger, and it's not letting pee out very easily. So one treatment is just that we cut that scar tissue out, like you can see they're doing in this surgery. That's just done straight through the penis. There's no incisions in the body. The problem with scar tissue, and this is what keeps me in a job, unfortunately, is that scar tissue tends to come back when you cut it. It's usually worth trying one or a couple of times, but if it's really, scar tissue that keeps returning, we have to do something a little bit more radical. So we can do a robotic revision of that of the bladder neck, where we really cut out all of the scar tissue and we sew healthy tissue back to healthy tissue. I mentioned that sometimes after men have had radiation, they can get scar tissue farther down in the urethra. That's called a urethral stricture. Radiation works by limiting some of the blood supply to tissues. That's how it hurts the cancer, but it's also how it causes side effects later on. So if people get strictures after radiation, depending on where the stricture is, we can usually fix it with a surgery, and that surgery is called a urethroplasty, which you can see on the next slide. Excuse me as I recover from my daycare cold here. This is a drawing of a urethroplasty. So we make that same standard incision in the perineum that we've talked about already. We dissect out the urethra, we find the scar tissue, we cut it out, and then we sew the urethra back together. Sometimes I take tissue from the inside of the cheek to patch where the scar tissue was to make the urethra wider. And that surgery also has really high success rates. Radiation is sort of the gift that keeps on giving. So sometimes people will have complications as the result of having had radiation. There are other more rare sequelae of prostate cancer treatment that can cause really bad bladder problems. So one of them is radiation cystitis. That's the picture you can see here on the right. The bladder just looks really angry and inflamed, and there's lots of blood vessels where there shouldn't be blood vessels. That can cause, recurrent blood in the urine, really bad urgency or pain. That's one problem you can have. Another problem is stones that form in the bladder. Those can form on the sides of where radiated tissue has been or where prior surgery has been done. I think if you keep on clicking, we'll see those. And then one of the most dreaded complications after prostate cancer surgery or radiation is called a fistula. A fistula is just an abnormal connection that's formed in the body between two things that shouldn't be connected. So the urinary tract, like the bladder or the urethra, can form an abnormal connection with the bowel, like the colon. Um, that's obviously a bad problem. The pee comes out where the poop should come out, and the poop comes out where the pee should come out. Really bad issues there. Um, these are all obviously more rare sequelae of prostate cancer, and some of them can require many surgeries. And even sometimes I remove bladders for this problem, and then we make an alternative reservoir for urine out of intestine. That's kind of beyond the scope of this talk, but just to know that from the minor to the really major um, problems after prostate cancer treatment, we've got plenty of tricks up our sleeve, and we can treat all of them. And I think that's my last slide, and I'll hand it off to Dr. Lindy to talk about erectile dysfunction.
Thank you, Dr. DeWitt-Foy. So we'll turn things over now to Dr. Lundy, who is going to go through some of the problems with sexual function that men can experience after prostate cancer treatment. Dr. Lundy, take it away.
Great. I first just want to thank you all for being here. I know this is a sensitive topic, and I applaud you for wanting to learn more about it and make informed decisions. And I want to relay that we're all here to help any way that we can, and we're here to help take care of you. So hopefully this information is useful, and and we'll dive right in. So first, we're going to talk about sexual problems that happen with treatment. Next slide. So this is just a diagram demonstrating what the penis looks like in cross section. So you can see here on the left, this is a flaccid penis. There are two erectile bodies, one on the left, one on the right. And then in between them at the bottom is the urethra that carries the urine. And we talked about that already. And so there's normally a small amount of blood flow into these structures. But when a man gets an erection, we go back to that other slide. Thank you. There we go. When the man gets an erection, these blood vessels enlarge and the spongy tissue inside fills with blood and becomes erect. And then what this does is this pinches off the drainage system for the penis and causes these small veins to pinch off and prevent the blood from leaking out. And this is what allows the penis to become hard. So you have to have adequate blood flow in, the lack of too much leakage out, and nerves and stimulation to coordinate the whole process. And with prostate cancer treatment, these structures can become damaged or not function properly. Next slide. So in general, erectile dysfunction is a really common problem, and we see this in men of all ages, but it is clear that as men get older, everyone loses a degree of their erectile function and has at least a component of worsening erections. In fact, about 2/3 of men have a diagnosis of erectile dysfunction by the time they reach age 70. And this is men with or without prostate cancer. So this is a very common problem. If we look at what causes erectile dysfunction in general, we see that the main problems are vascular problems with blood flow in being limited or blood inappropriately leaking out of an erect penis. Diabetes is a big one here because it affects the nerves that supply the signals to the penis that promote an erection, and also the blood supply into and out of the penis. And then at the bottom there, you'll see that pelvic surgery is also a part of this as well. And so prostatectomy or other treatments for prostate cancer certainly cause worsened erections, and this plays a role in a significant number of men. Next slide. So of the 100,000 prostatectomies every year in the United States, a proportion of those men will go on to have erectile dysfunction. And if you read the literature and ask the surgeons involved, this number varies widely. And that's primarily because people use different definitions of what erectile dysfunction means in this case. In any event, the erections after surgery often worsen significantly almost overnight, and then can begin to recover over time. Even as far as 2 years out of surgery, men can have an improvement in their erectile quality after this surgery. In contrast, men who've had radiation treatment often have minimal effect on their erections early, but this effect becomes compounded over time and the erections worsen as time goes on. So if we talk about who has the highest rate of problems with erections after prostate surgery, we see it's typically the gentlemen who have surgery at an older age and those who have diabetes before the surgery or hypertension or other medical problems. And then finally, if the prostate cancer is such that we are unable to spare the nerves that run alongside the prostate during the surgery, this typically results in a more profound loss of erection function as a result of the surgery. So just like the urinary problems we saw earlier, erection problems really are common. And if we look at the data from one of the large studies that's been published on this, you can see that an erection that is insufficient for intercourse is present in 90% of men at 15 years after their treatment. And the bother for this is also quite high, where at 15 years, about 40% in each category have some bother by this lack of function. And what I want to highlight is that this is present in both groups, either radiation or in surgery. Next slide. So I just quickly want to mention the role of testosterone in all of this, because I think it's a hot topic and there's lots of discussion about this, both amongst patients, but also amongst providers. We know that testosterone is an important factor for erections and particularly for sex drive. And we know that as men get older, the testosterone levels drop. We also know that men who have prostate cancer often have abnormal testosterone levels, but that treating these men with testosterone can in some cases be unsafe because it will cause the prostate cancer to grow rapidly. Now, this is not the case for all men with prostate cancer, and we now know that some men with prostate cancer can be treated safely for their low testosterone and have significant improvements in their quality of life. But this is an ongoing area of research, and it's a decision that has to be made between you and your provider who knows your history well after a long and thoughtful discussion about the risks and the benefits. So we're going to jump into the actual treatments for erectile dysfunction now, and we'll start with the least invasive and move towards the most invasive. And the first are medical treatments of pills called phosphodiesterase 5 inhibitors, or PDE5 inhibitors. This is a medication that works quite well. Many of you know it as Viagra or Cialis, or their generics, which are sildenafil and tadalafil. It's important to note with these medications, while the effectiveness is high, you still have to have the same mental and physical stimulation that you did without the pills. This just simply augments the ability for you to get an erection. This medication is safe, it's reliable. It does have some side effects in a rare group of men who take it, and the main ones that we see are headache and flushing. Sometimes men can have a blue tinge across their vision as well with Viagra. And this is not harmful, it simply means that the medication is acting in the eyes on a slightly different receptor. There's some nasal congestion, but overall, these medications are tolerated quite well. Men who have nitrates as a medication that they use regularly cannot take this class of medications. And it's very important to highlight that these two cannot be mixed, or it could be life-threatening with a drop in blood pressure. Also, patients who have severe cardiac disease and who are unsafe for intercourse should also not take these medications. Nevertheless, these medications are widely used. They're very affordable now. We have multiple sources for the generic medications where even men who take this every day may only pay several dollars a month for an entire month's worth of supply. So it's often the first thing that we try when we talk about treating erectile problems. Next slide. Next is a vacuum device. This is another one of those barbaric devices similar to what Dr. dewitt-foy showed earlier. This is a device that you put over your penis and usually either pump a pump or hit a button where an electronic pump then creates a vacuum. And this pulls blood into the penis through that vacuum. And then you trap the blood with a little constrictive band that goes at the base of the penis. The benefits of this are that it's a one-time purchase. Medical grade devices cost about $300. And this device can be used as much as you'd like. The downsides are that you're limited in terms of the duration of use because it also limits the blood supply into the penis and can cause damage if it's left on for too long. This also can cause some bruising or some pain. And so what we find is that some men have satisfaction with this and derive benefit from it, but many men end up going on to other treatments after this device isn't working for them. We talked a little bit about this already, but bruising is relatively common. And the other thing to point out is that this only fills the part of the penis outside of the body with blood, not the other half of the penis on the inside of the body. And this results in a somewhat unstable erection because the penis, while normally anchored to the pubic bone, is not anchored in the same way with this device. So you have to be a little cautious with its use. If you have structural abnormalities of the penis or you're not able to get a good seal and create a vacuum, then this device won't work for you. Next slide. Next is shockwave therapy. And I'm sure everyone or near everyone on this call has heard about the advertisements for this technology. It is our newest treatment for erectile problems. And it essentially consists of a provider delivering low intensity ultrasound energy to the penis over a period of 6 weeks. Now, there's actually 2 different kinds of shockwave therapy, and it's very important to recognize which therapy you're being offered. The first is radial and the second is focused. Radial is a type of technology that's often also called Gainswave or other proprietary names. And this is now a technology that has been used widely, but unfortunately does not have much data to support its use. And the most recent trials that have examined this have shown that this really offers no benefit whatsoever for the treatment of erectile dysfunction within the constraints of the data that we have. On the other hand, focused shockwave therapies can, in some cases, offer a benefit, and we do have limited data now to support its use. But the most important takeaway from this slide is that the benefit, if it occurs, is modest. So if you're at a 5 out of 10 erection and you want to get to a 6 out of 10 erection, or maybe a 7 out of 10 erection, then this might be something to consider. Or if you're currently a 7 out of 10 erection, but you want to stop taking pills and maintain that same degree of erectile quality, then this is an option. But this is not for everyone. And in particular, if you've had a prostatectomy, the data that we have suggests that this may not be the right treatment for you. It's a safe treatment. There's very little in terms of side effects, maybe some intermittent pain or bruising, but this is quite uncommon. If you have bleeding problems, this is not the right treatment for you. And finally, because this is such a new technology, this is not currently covered by insurance and is quite expensive. So the cost varies around town. At our institution, this is $1,800 for a 6-week cycle. So what I find is that it's an option for some men, but I tend to talk more people out of it than into it because I want the patients that I see who are considering this to have realistic expectations for whether it's going to benefit them given that high cost that you see there.
Scott, I just want to interject with a quick question for clarification. So oftentimes patients will come in and ask me about advertisements they've been mailed, they've seen in the newspaper, they've seen on TV or heard on the radio about shockwave and treatments at different places around town.
Mm-hmm.
We know that most of those are radio wave treatments. How common is focused shockwave therapy? How common are those machines? Are they widely available?
Yeah, that's a great question. They're far less common, and it's difficult to determine which machine you will be treated with, even if you ask the question directly. I want to point out that the radial machines are not regulated by the FDA, and those treatments can be delivered by a non-medical professional, which is very different than the focused shockwave. And so I would encourage you to do your homework and ask these focused, pointed questions wherever you seek your treatment to ensure that you know what type of treatment you're receiving. Because in most cases, as Dr. Gill said, it's not focused shockwave therapy. Next slide. I want to quickly talk about platelet-rich plasma, or the P-shot. This is an idea where blood is taken out of a patient and then separated into its components, and a certain component called platelet-rich plasma is then injected back into the penis. This has been used in other disease processes and is another newer treatment for erectile dysfunction. Next slide. This treatment has really no evidence to support its use at this time. Not to say that in the future this may not have evidence to support it, but as of now, we have little to no data to suggest that it is efficacious. And it is also another treatment that is quite expensive and does have some side effects, including scarring and bruising. So this is a treatment that we do not offer at this time because we have not yet been convinced that it is a viable treatment for erectile dysfunction, although there are clinical trials ongoing at other institutions across the country. Next slide. So next is a Muse, or a urethral suppository. This is a device that has been put into place many years ago, where a small pellet containing a medication called alprostadil is placed inside the urethra with this applicator that you see here. Again, another medieval torture device, but this is placed inside the urethra and then it's absorbed into the penis to allow for an erection to occur. Next slide. So this is modestly effective. I think a 50% effectiveness number is probably a little optimistic, but it also causes some burning and some pain. And it's important to note that this can also occur in the partner of the patient as intercourse occurs. And so what we find is that while this is a viable option, I think we all routinely use this less and less because other treatments are more efficacious and have less side effects. Next slide. If you have hypospadias or Peyronie's disease, this is not the treatment for you. And if you have a urethral stricture, or if there are concerns for developing one, then this is also not a good treatment for you. And finally, this is an extremely expensive treatment. Per use, these cost upwards of $80. And so again, it's not something that we use on a daily basis anymore. Next slide. So injection therapy is next. This is where we get into the more involved treatments. And essentially what this involves is a self-injection of medication directly into the erectile tissues of the penis, of varying concentrations and dosages and types of medications that we can mix together. This treatment typically works. It is an efficacious treatment and it works relatively quickly. 5 to 20 minutes is the normal range that we see. It works without much stimulation in many cases too. So this is a little bit more of a quick onset and doesn't require other additional maneuvers to work. So obviously this requires an injection into the penis. And so you want to be sure that if it's something you pursue, it's something that'll work. And as I said, it is quite effective, but there can be bruising associated with that. There can be some pain associated with it. And there is a theoretical risk that over time, with repeated injections, you can form scar tissue. And that scar tissue is something called Peyronie's disease. And that can be exacerbated by injections if it's already present or if you inject multiple times in the same spot. The other main side effect or risk to be aware of is something called a priapism. A priapism is a long-term erection that doesn't go away on its own and causes permanent damage to the penis and the erections if left untreated. And while this is rare, there is a risk when using these medications that this can occur. People who have Peyronie's disease, as I said, should likely forego this treatment, or at least there should be a long discussion about whether it's appropriate. And then finally, this is not covered by insurance in most cases, and there is a cost associated with each injection. That cost is relative to how many doses you can use out of a single vial and how much medication you're using. Finally, I'll mention that this requires needles and syringes, and the medications must be kept cool to work. And so for people who travel a lot, this is often cumbersome. So now we enter the surgical realm, and the first surgical treatment that we have is something called a malleable penile prosthesis. So these are devices that we place inside the erectile tissue of the penis and replace that tissue with an artificial device. And in this case, these are two metal bendable rods that are covered in a soft, pliable material. A malleable device is surgically implanted and you bend it to the shape that you desire, either downwards when the device is not in use or upwards when the device is to be used. And the benefits of this are that it provides a reliable option to achieve an erection that's satisfactory for penetration. Next slide. This is also a relatively straightforward surgical procedure. And if you're someone who is at high risk for long periods of general anesthesia, then this operation can be done fairly quickly, and the recovery is also fairly straightforward. It's important to note that with this device and with the next device, the inflatable device, in most cases, ejaculation, penile sensation, and orgasm are unchanged. This really only provides the erection that men are looking for to have a functional penis capable of penetration. It's important to note that this is a surgery and there are risks with that, and it's typically done under general anesthesia. You also lose the ability to have spontaneous erections after placement of these devices. So if they ever have to come out, for example, because of a risk of infection that occurs, then without placement of a new device, you will no longer have erections on your own. Although most men who are ready for this honestly don't have much in the way of functional erections anyways. The other big risk that we see is erosion, and that's where these devices leave the body and form a new tract to the outside world. And this is, of course, a problem, and these devices need to be removed if that happens. Next slide. The final treatment that we'll talk about tonight is the inflatable penile prosthesis. This is a device that is surgically implanted into your body, and it's a hydraulic system composed of 3 components. The first is a pump that's placed inside your scrotum. This is essentially like a third testicle in terms of shape and size, and it sits under the skin. You wouldn't necessarily know it was there by simply looking at the scrotum, but you can feel for it. And this is connected through a series of tubes to a reservoir of fluid that's hidden inside your belly where you can't feel it. And then these structures are then connected to 2 cylinders that we place inside the erectile tissues of your penis, one on either side. Again, they replace your erectile tissue. So after this device is placed, you're no longer able to have spontaneous erections. So when you want to use the device, you pump up this pump inside your scrotum, just old Nike Air shoes, for example, if you're familiar with those. And that moves the fluid from the reservoir into the cylinders and provides you a nice firm erection that's capable of penetration. This is a picture of what these devices look like. They're all placed sort of in a ship in a bottle fashion through a 1-inch incision that can either be above or below your penis. And then we connect everything together inside your body. And then we allow you to recover. And several weeks down the road, we teach you how to use the device. Now, this seems like science fiction, but this is actually our oldest treatment for erectile problems and has been in use for about 50 years now. Next slide. It's also our highest satisfaction option, where 90 to 95% of men who have this surgery are satisfied, and 90% of the partners are also satisfied afterwards. We anticipate the device lasts 15 to 20 years with modern data, although there are some that fail earlier than that because of mechanical problems or infection, which we'll talk about. And it's also important to know that ejaculation, sensation, and orgasm are also unchanged. The glands of the penis, however, with this operation does not engorge like you may be used to now. So it's important to note that if you want that aspect of an erection, you'll need to take a Viagra or a medication for that to occur. In terms of side effects and risks, this is a larger surgery than the malleable device we just talked about. The recovery for this is anywhere between 4 to 6 weeks, depending on the approach. And the greatest feared complication is an infection, which happens in about 1% of most men. If you're a diabetic or if you have other risk factors, this number can rise. And so we're very cautious in offering this treatment to men who have uncontrolled diabetes or other significant risk factors for infection. And it's important that we really do everything we can to optimize you before we put you through this operation to ensure that you have the highest chance of success. If the device becomes infected or if it mechanically stops working, in many cases we can replace it with a new device, but in some cases, particularly with a severe infection, we have to wait and let the infection be treated, and then we have to attempt a device again in the future. So it's not always a guarantee that we can do that. The final thing I'll mention is that you have to have the dexterity to squeeze this pump in order for this device to work and for you to be to achieve the effects that we're looking for with it. So if you have difficulty squeezing the pump, then the device may be difficult for you to use, and your partner may be called to assist. So I'll turn it back over to Dr. Gill, and I'd like to thank you all for your attention. We'll happy to answer questions.
All right. Big thank you to Dr. dewitt-foy and Dr. Lundy for sharing their expertise with us. As mentioned at the beginning of the presentation, we see patients all around Cleveland, as do a number of our partners who also have skills and expertise in these areas. So we have a great team, many of whom have extra specialized training in treating conditions like urinary incontinence and erectile dysfunction, urethral stricture, all of the various things that we've talked about. We're very fortunate to have Dr. dewitt-foy and Dr. Lundy with us on the team to share their expertise with our patients. So, you know, as we went over, prostate cancer treatment does have risks and there are side effects, and these exist for every different type of treatment that there is. Most of these improve with time if you've had prostate surgery, and with radiation, they may become more severe with time. So there really is, you know, no treatment where you don't have a chance of experiencing a side effect. However, that said, as we covered here, all of the symptoms of treatment, prostate cancer treatment, can be improved with a variety of medical or surgical therapies. And this treatment really does carry huge benefits for quality of life. That's a lot of what we treat in our practices, trying to give men back the ability to be physically active and not be constrained by leakage, and also to be sexually active and enjoy that part of their lives. And again, we're here to help. So with that, we'll open up the Q&A session. I'll leave the slides up here with everybody's information. If you'd like to make an appointment, that's our number for the appointment center on top. If you'd like to follow us on Twitter, all of us are fairly active on there with a good mix of medical information and then also maybe some urologic humor sprinkled in. So we'll go ahead and look and see what we have here in the Q&A box. Dr. DeWitt, Dr. Lundy, feel free to chime in. Looks like we responded to some of these already. All right. Here's a good question on incontinence and erectile dysfunction with HIFU treatment. Would either of you like to take a swing at that one?
I think I answered this question in the chat. I would say the difficulty with HIFU is it's a slightly newer, well, it's definitely a newer technique for treating prostate cancer. And the way that we do HIFU has really evolved over the last couple of years. So, you know, some people get full gland HIFU, some people get, you know, partial gland HIFU that's just focal. And the side effects that you can get from HIFU really depend on who's doing it and how much of the gland is being ablated. So it's a hard question to answer. You know, generally the data would show that the rates of erectile dysfunction and incontinence tend to be lower with men who've had HIFU. Although again, that's with the big caveat of saying that HIFU is like comes in many flavors. And it would be best to talk to the person who's doing your HIFU about what kind of HIFU you're going to get and how much of their gland you're going to treat and what side effects they would expect for you. You know, because it's kind of like radiation, there can be some of those sequelae like you know, stenosis of the bladder neck or stricture. So certainly side effects are possible. You know, the rates of erectile dysfunction tend to be lower.
Yeah, I would echo that. I think location really is the key, right? Just like in prostate surgery, if you go in for prostatectomy with a cancer that's confined and within the prostate, you may have a better chance of being able to have a nerve-sparing operation. But if that cancer is more advanced and it pushes out into the nerves that produce erections, you may need a more, you know, in-depth surgery to get rid of all the cancer, and the nerves may have to be taken as part of that.
I'll just answer. There was a question about if you're having a prostatectomy, what can you do to minimize the chance of scar tissue forming between the bladder neck and the urethra? There's nothing you can do to prevent it. Having radiation before or after a prostatectomy definitely increases the risk. Your risk of any complication is higher if you have things like diabetes, high blood pressure, obesity, all of that kind of stuff. But a lot of it is just bad luck, and some of it has to do with surgical technique.
There's a question here about the side effects of seed implants. Dr. Lundy, any thoughts on those?
Yeah, so we didn't talk much about the specifics of radiation here, but radiation comes in two primary flavors. One is external, where radiation is applied from outside of your body, and that is attempted to be focused directly on the prostate, but there is some leakage to surrounding organs like the bladder or the rectum. There's also brachytherapy or seed implants, where small pellets are placed inside the prostate in a particular geometric fashion, and this over time releases radiation and treats prostate cancer. We as an institution here have a quite significant experience with brachytherapy, and I believe have done more than anyone in the country. And in general, brachytherapy is well tolerated, and it's a very appropriate treatment for prostate cancer. It is still radiation, and many of the treatments that, many of the complications that we see from radiation from external beam also occur with brachytherapy to varying degrees. So things like stricture can occur, things like necrotic prostate tissue that cause irritation can occur, things like fistula can occur where there's an abnormal connection between different structures. And so the risks for brachytherapy are similar to the risks for external beam in terms of the various categories of them, although there are slight different incidents of those between the two.
There's another good question here about doing Kegels. Should I continue my Kegel exercises even if I have not experienced incontinence after having my prostate removed? I think that's a great question. So one thing that we know is that as the bladder ages, it becomes a little bit more unstable, a little bit more impatient, and the rates of leakage problems in men increase with age. And that's even in men that haven't had prostate cancer treatment. That's just across the board. The muscles that you exercise with Kegels, you're exercising the sphincter to strengthen that and improve your ability to control urine. That may be a helpful thing as you age with the prostate not being there. So, my opinion on that would be it probably is of some benefit, and it's definitely not to any detriment. So throw some Kegels in your daily workout routine.
The only caveat to that is I have seen some people do so many Kegels that they get pelvic floor dysfunction, which is sort of like if you went to the gym and went 5 times a day and lifted too many weights, you could get muscle spasms. You can get muscle spasms from your pelvic floor. Doing a Kegel exercises when you brush your teeth twice a day is totally safe. If you're starting to have pain, trouble defecating, or trouble urinating with your Kegel exercises, then I would say back off.
All right, we have another question here. Dr. Lundy, we'll throw this one your way. Are the side effect percentages lower for ablative treatments?
So that's a bit of a catch-all, and it's a nuanced discussion because ablative treatments can apply to multiple different types of energy to destroy prostate tissue. That includes things like cryo, where the tissue is frozen, or HIFU, where the ultrasound waves are provided. There are lots of different interpretations of that, and so I think it's hard to really generalize that and say that the side effects are lower. Certain side effects are higher when the ablative treatments are used, and particularly things like fistula we worry about, and so irritative symptoms and these sorts of things can occur. So it's hard to really generalize, and these are great questions that really are best posed to your doctor, who knows where your cancer is relative to your prostate and to what degree the ablative treatment needs to be used, whether it's the whole gland or half the gland or focal within a certain portion of the gland.
Excellent points. There's a question here about prostatectomy after brachytherapy. And those patients in general have quite a few side effects to deal with, many of which are relevant to Dr. DeWitt-Foy's practice. So any thoughts on that?
Yeah, I just answered that question in the chat. And there's another question about combination of external beam and brachytherapy. I think you have to get whatever you have to get to treat your prostate cancer. Unfortunately, combination therapy tends to have higher side effect risks. So brachytherapy plus external beam has higher complication risk than one or the other alone. Prostatectomy after brachytherapy, for those of us who've done those surgeries during training, which I think is all three of us, those are humbling operations. They're more difficult, and your risk of erectile dysfunction and incontinence is unfortunately higher after a prostatectomy when you've already had radiation. But the point of our practice, of me and Dr. Gill and Dr. Lundy, is to help people manage complications. So we don't say no to people. We're just going to help you try to manage the complications in a way that's safest for you and best based on your presentation and everything that you've got going on. So not everyone's going to be a surgical candidate, but we're always happy to help, see people and help you manage whatever complications you might have.
All right, I'm going to take another swing at a question in the chat box here. I'll really two of them. One is a question on advertisements for CyberKnife. Is this a type of radiation treatment? And then there's another question about another advertisement where a group is claiming to use low-dose brachytherapy and external beam radiotherapy with fewer side effects. So those are both marketing tactics. So CyberKnife is basically a brand name for focused radiation, which nowadays, if you have external beam radiation to treat your prostate cancer, it's all going to be conformal therapy, 3D therapy, focused, radiation beam therapy. They're just different names to really the same kind of treatment. Many people will argue the same for proton therapy too. It's just different machines, aiming radiation with slightly different systems. And there's never really been good head-to-heads showing that one is better than another, but all of which can be effective. With regard to the group using low-dose brachytherapy and claiming fewer side effects with that and external beam therapy, all brachytherapy nowadays for prostate cancer is low-dose rate brachytherapy. They no longer use high-rate brachytherapy, which is where they use needles rather than radioactive seeds. So again, this is a marketing ploy where a company is using standard of care, the same treatment that you can get anywhere else, but putting it under a different name or trying to spin it in a different way to attract patients. As Dr. dewitt-foy pointed out, if you use combination radiotherapy, brachytherapy, and external beam therapy, you're at a much higher risk for side effects and problems from your treatment. But unfortunately, some cancers require that more, aggressive, that higher intensity of treatment.
And just to piggyback on top of that, Dr. Gill, there's even some evidence to suggest that treatments like proton therapy, which are newer and more modern than some of the other treatments, may have increased side effects.
Absolutely. There's a question here about when the seminars will be distributed. This will be posted online and information will be distributed afterwards via email, so stay tuned. You should be getting that information shortly after the conclusion, if not within the next day or two. Another question here, how long do I have to wait with incontinence before a surgical intervention? So I'm interpreting this question to mean after my prostate cancer treatment, how long out do I need to be to have my incontinence treated? Dr. dewitt-foy, what are you thinking?
Again, there's not a specific answer for every patient. I think if you've had a prostatectomy, there's some data to show that urinary control can improve up to a year after surgery. It would be, if you're horribly bothered by it, it would be totally reasonable to schedule an appointment to talk about, surgical management and what we could do. Certainly I would wait at least 6, 7, 8 months before scheduling that appointment. And then I would probably wait a year after surgery to get an artificial urinary sphincter or a sling.
In essence, you want to give both the maximal time for recovery and see how good a patient can get, but also allow those tissues to recover from the surgery or radiation. Dr. Lundy, does insurance cover the implanted ED devices, specifically the inflatable prostheses?
Yeah, it's a great question. As you saw in our presentation, most treatments for erectile dysfunction are not covered by insurance. The exception is the penile implant, which is by far the most expensive treatment, but is nearly uniformly covered by insurance with certain caveats for certain insurance companies. And so if we discuss this in clinic, if a patient is a good candidate and we recommend it, then the majority of patients who would like to have the device can. And we always do ensure that insurance will cover the procedure before we proceed, because we don't want patients to have a surprise bill. That's the last thing we want. So the answer is yes, it is covered, and we confirm that before we proceed.
Yeah. And if you're on Medicare, which a lot of our prostate cancer patients are based on age, Medicare covers these. Question for Dr. Lundy. Any thoughts about orgasmic dysfunction, specifically the ability to have an erection but no orgasm? How will that change with prostatectomy?
Yeah, that's a great question. So first, I just want to separate the concepts of orgasm and ejaculation in everyone's minds. So while we as men often attribute that orgasm, that pleasurable sensation, as happening at the same time as ejaculation or the release of fluid, this is not always the case. And if a man has had a prostate removal surgery, he will not ejaculate in the least, but you will still be able to have an orgasm. Now, in the case where you're able to have an erection but an orgasm is difficult, then there's a number of potential reasons why, and those may be related to the prostatectomy or radiation therapy, but they may not be too. So this is a discussion we have in clinic about the potential avenues for diagnosis and treatment for this problem. And one of the key focusing factors for me is hormones, and make sure that the hormone levels of various hormones are at the correct values. And if that is indeed the case and we're still having problems, then there are some medications we can use to help with this problem. And there's also a role in this case for things like sex therapy, where we have psychologists whose entire practice centers around helping men with their sexual satisfaction. And we trust them implicitly. They do a great job, and we can place the referral for you if that's something that you're interested in.
All right. We did answer start a couple minutes late, so we'll answer one more question here. I think Dr. dewitt-foy was typing a reply there to it. So Dr. dewitt-foy, in men that are having incontinence procedures, does that close any doors for the treatment of erectile dysfunction?
So assuming we're talking about stress incontinence, meaning surgeries like an artificial urinary sphincter and a sling, they don't close the door for getting treatment for erectile dysfunction later. Usually if we're going to do an artificial urinary sphincter and an implant on the same patient, we usually do the artificial urinary sphincter first. But there, you can definitely take Viagra or other pills for erectile dysfunction and have treatment for your urinary incontinence. I know a lot of men, want to fix the urine first because they don't want to have an erection and have an orgasm with a partner when they're having really significant incontinence. And then just from a surgical staging standpoint, it usually makes sense to fix the incontinence first. Dr. Lundy, any other comments on that?
No, I think that that's very reasonable. We often see men with both problems, and we treat men with both problems. And we tend to stage them, as Dr. dewitt-foy said. We don't tend to do both at the same time any further for a variety of reasons. But we can't avoid treating one just for the other. And in many cases, we also look to you to tell us which one is most bothersome, and we take that into consideration.
Absolutely. Well, we'll wrap up with that. I'd like to give a huge thanks to Dr. dewitt-foy and Dr. Lundy for sharing some of their time with us and their expertise in extra training and in treating a lot of these problems. We're really fortunate to have them with us here in Cleveland. All of us are happy to see you anywhere around town, as well as our partners who manage many of the same conditions. Feel free to reach out and let us know if you need anything. Also, as mentioned, keep an eye on your email for follow-up information from tonight's session. And the last charge I'll give you is make sure that you're talking to the other guys in your life about prostate cancer screening, treatment, or getting side effects taken care of if they're dealing with them after being treated. There's things to do for that. There's things that we can do to help, and we're all here to help take care of you. So have a great night. Take care and stay healthy. Bye.
Thanks.